Hello friends, so here we're going to talk about acute leukemia, and acute leukemia can occur to either the lymphoid line or the myeloid line. So we have acute leukemia is really multiple syndromes. So there's AML, which occurs to the myeloid lines, acute myelogenous leukemia, and ALL, acute lymphocytic leukemia. So we'll talk about both of these. So remember, leukemia, what you're going to see is a proliferation of blasts in the peripheral line. So you're going to more so see this in acute leukemia, but in both acute and chronic leukemia, there will be an increased level of blasts. And blasts are just immature white blood cells. Okay, so overview of acute leukemia. So unlike chronic leukemia, acute leukemia is a very rapid onset of myeloproliferation in a clonal line. Both acute and chronic leukemia are this myeloproliferation where we get a line of cells. Remember, a line being starting from the stem cell, going all the way to the mature cell of destiny. You're getting a myeloproliferation, so a proliferation of one single cell line that's deranged. However, in acute leukemia, it's a rapid onset, whereas in chronic leukemia, it's a slower onset. And generally, in chronic leukemia, the cells tend to be more functional, whereas in acute leukemia, the cells are non-functional. So in acute leukemia, because this happens so fast, it dramatically affects the bone marrow. And not only that, but it consumes the resources that are necessary to make blood cells. So if you're making basophils, for instance, and they're non-functional leukemic basophils, and you're making tons and tons and tons of them because you have this clonal proliferative cell line, you're not going to have the resources to make red blood cells. You're not going to have the resources to make platelets. And so in acute leukemia, not only does it affect the bone marrow where you get this myeloproliferation, but it's also consuming resources. And so it's going to lead to a pancytopenia. Remember, pancytopenia meaning all cell lines low, pancytopenia. So this leads to the characteristic presenting symptoms where we have low red blood cells, low platelets, and low functioning white blood cells. So as a result of the low red blood cells, we're going to have anemic symptoms. So fatigue, weakness, shortness of breath, dyspnea, pallor, blanching of the fingernails, and so forth. With thrombocytopenia, there's easy bruising and bleeding, particularly the easy bruising. And then with leukopenia, and I struggle to use leukopenia here because really the white blood cells can be elevated, normal, or low, because when you have leukemia, you may have a proliferation of white blood cells. They're not functioning, but they're proliferation of white blood cells, and that can read as an elevated white blood cell count. But either way, you're going to have an increased susceptibility to infection. Why? Because the white blood cells that proliferate in acute leukemia are non-functional. They're immature. So even if you have a white blood cell count of 100, that's high, you're going to have an increased susceptibility to infection because the white blood cells created in acute leukemia are non-functional. So the clonal line can be, as mentioned, myeloid or lymphoid in lineage, but the symptoms are going to be clinically indistinguishable. So you're going to get the same syndrome where you're getting anemic symptoms, thrombocytopenic symptoms, and leukopenic symptoms. However, it's going to be indistinguishable. You're not going to be able to tell AML from ALL in a patient with these symptoms. So you'll have to get a bone marrow biopsy for that. As far as acute leukemia, there's always going to be an increased risk with genetic disorders and exposure to various carcinogens. So nuclear carcinogens tend to be the most commonly known. However, there are other carcinogens such as benzene, radiation, and other chemotherapeutic agents that can lead to acute leukemia. It's not uncommon for a patient to get chemotherapy for breast cancer or chemotherapy for brain cancer, and then they may be successfully treated for that cancer, but they wind up developing leukemia as a side effect of their chemotherapeutic. Acute leukemia in general, both AML and ALL, are more common in children. Chronic leukemia is most common in older people, adults over the age of 50. Acute leukemias are what we see in kids. So if a kid has leukemia, you can hedge your bet that that kid has an acute leukemia. However, acute leukemia can happen in adults as well, and it can happen in older people. So, but when leukemia happens to a child, it tends to be acute leukemia. And ALL is most common in children. Okay, so acute leukemias, both AML and ALL, is a rapid onset of myeloproliferation in a clonal line, as mentioned. And the characteristic symptoms are related to the pancytopenia. So anemia, thrombocytopenia, and the decreased functional white blood cells, which could read on your CBC. It could be a high white blood cell count, could be a normal white blood cell count, could be a low white blood cell count. The fact of the matter is the white blood cells that exist, because they're leukemic, they are non-functional, and so the patient has an increased susceptibility to infections. Other symptoms that can happen, and this tends to happen more in ALL, but it can happen in either, and that's just because the lymphocytes tend to be more proliferative than the myeloid lines. And that can include splenomegaly, hepatomegaly, painless lymphadenopathy, and really bone pain can go for either. But this happens due to proliferation. And the bone pain, because you've got proliferation and in the bone marrow. So the splenomegaly and hepatomegaly are due to infiltration of the blood cells into those organs. Lymphadenopathy, of course, this would be just a generalized lymphadenopathy. So those can all be signs of leukemia. But definitely remember your symptoms related to pancytopenia. Now, there's a special kind of AML, acute myelogenous leukemia, that tends to present or can present with signs and symptoms related to DIC, disseminated intravascular coagulation. And so it can present with petechiae and ecchymoses, it can present with jaundice, it can present with it wouldn't be a presenting sign, but you could have an increased fibrinolysis. And so that's a specific AML to look out for. Now, on USMLE Step 1, you have to remember AML type M0, AML type M1, AML type M2. You don't have to remember that for Step 2 and Step 3. This is not a pathology-based test. But what you do need to remember is M3 is a unique AML that can present differently and is treated differently. So remember that this AML, M3 AML, or acute promyelocytic leukemia, is highly unique. It can present with signs and symptoms related to DIC, and it's treated differently, and we'll talk about that. So diagnosis is going to be pretty straightforward. So you get a CBC on pretty much everybody that comes into the hospital with significant symptoms. And so you'll have your CBC, and it's going to be very, very, very straightforward because you're going to have pancytopenia. You're going to have a patient with low red blood cells, low platelets, and deranged white blood cells. I suppose it could be high or low or normal, but the fact of the matter is you should not have anemia and thrombocytopenia together in any patient. And so the two of those together, plus increased susceptibility to infections and the symptoms, those are all suggestive of leukemia. Now, and another thing also is if you order a smear, which you always should really in any patient when you're getting a CBC, that smear will show immature blasts. And so those immature cells that are indeed the leukemic line that's causing the disease, those will proliferate out into the peripheral circulation, and those blasts will be seen on the peripheral smear. And that's just another sign suggestive of acute leukemia, in addition to the symptoms and the pancytopenia and so forth. So when you have all of these signs and symptoms and lab signs present, then you're going to need to get a definitive test. A CBC is never definitive for leukemia, even if you do have blasts. So when you have pancytopenia in the presence of a symptomatic patient, the best initial and really the best final diagnostic test is a bone marrow biopsy. It's going to be through a bone marrow biopsy that you're going to be able to definitively diagnose that this patient indeed has acute leukemia or not, and you're going to be able to definitively diagnose what type of acute leukemia they have, either AML or ALL, and you'll be able to definitively diagnose what type of AML they have if it is indeed AML. That's the disease. So a bone marrow biopsy is, as mentioned, the best test for diagnosing acute leukemia, and it's going to help you differentiate between AML and ALL. By definition, and please remember that step 2 and step 3 are not cytology, biopsy, pathology tests. You're not going to have to read, you're not going to have to look at a slide of bone marrow, but you do need to remember some basics about what the biopsy says. So what you do need to remember is that in order to diagnose acute leukemia, there has to be greater than 20% blasts present on biopsy. You don't need to know what blasts look like, but you need to know that greater than 20% blasts need to be present on the bone marrow biopsy. In AML, on biopsy, our rods are going to be present. You don't need to know what they look like. Unlike on step 1, you probably remember, but you don't need to know what they look like. Just know that our rods equal AML. And the leukemic cells are going to stain positive for myeloperoxidase. How do you remember this? Acute myelogenous leukemia, myeloperoxidase. So they'll stain positive for myeloperoxidase and they'll have our rods. You should remember that. Even though this isn't a pathology test, you won't see a slide of this, you've got to remember that those are present. In contrast, ALL on biopsy, the leukemic cells will be positive for CALA, which is common acute lymphocytic leukemia antigen, CALLA. They'll be positive for that, and they'll be positive for TDT, and I don't honestly remember what that stands for. It's like terminal deoxytranspeptidase or something like that. So CALA and TDT are positive in ALL. Our rods and myeloperoxidase are in AML. In both, you have to have at least 20% blasts present on biopsy. And if you have a patient with AML, the pathology report will tell you if it's M3 AML, and you should suspect possibly M3 AML if the patient presents with signs and symptoms consistent with DIC. Okay, so the treatment for acute leukemia is always going to be chemotherapy, and we're going to do this in any patient no matter what. Unlike in chronic leukemia, where we could take a watch and wait approach, in acute leukemia, we're going to always jump right into chemotherapy. There's 2 phases to chemotherapy, 2 main phases, which include induction, and that's the initial, more intense phase, and this occurs over days, and then the consolidation phase, in which this is done over months, and this is less intense, but it's going to require hospitalizations every week to 2 weeks, depending on the patient. You don't really need to know the intricate details of treatment for acute leukemia. I mean, it's very, very, very intricate, but you do need to know the basics of how we treat AML and ALL. So, of course, it's chemotherapy. So for AML, we're going to treat with cytosine rabinoside, and that's known also as Ara-C or cytarabine, and this is just a nucleoside analog inhibitor, and so that's the treatment of choice for AML, so Ara-C, and then we also use daunorubicin or idarubicin. So 2 drugs, Ara-C and daunorubicin or idarubicin. If the patient has M3 AML, so remember that's the acute promyelocytic leukemia that can present with DIC. In addition to these drugs that we use for any of the AMLs, we also add all-trans-retinoic acid. And all-trans-retinoic acid is going to help the cells that are leukemic. It's going to help them mature. And that's important because basically what we have in any leukemia is a block in maturation. The cells can't mature, and so they wind up proliferating. And with APML, what we have is a block that can actually be ameliorated by giving the patient all-trans retinoic acid. And so ATRA, all-trans retinoic acid, is a necessary component of the therapy for a patient with M3 AML. And that's why it's important to know if the patient has M3 AML. Acute lymphocytic leukemia, you need to remember these 4 drugs. So daunorubicin, vincristine, and prednisone, and those are all given IV. And then you also have to treat the patient with methotrexate, and that's given intrathecally, and that's done as a prophylaxis. Remember that lymphocytic leukemia, any of the lymphocytic leukemias, they have a higher predilection for infiltration of any of the organs, and as well infiltration of the CNS. So we give methotrexate intrathecally to prevent the ALL from spreading into the nervous system. So daunorubicin, vincristine, prednisone, and methotrexate intrathecally. If the patient has gotten chemotherapy but they relapse or they have a poor cytology prognosis, then you need to give the patient a bone marrow transplantation. And bone marrow transplantation is the best definitive treatment for acute leukemia in general. So the general care for acute leukemia outside of the chemotherapy, so pancytopenia, which remember is not only part of the symptoms, but it's also part of the complications of leukemia. We treat it expectantly. So we're going to transfuse the patient with packed red blood cells if their hemoglobin drops below 7 to 8. We can be a little bit more liberal in kids, let the hemoglobin drop maybe down below 7. Usually we don't want it to go below 7. With older adults, obviously, if they've got cardiovascular or respiratory disease, we're much more concerned about a lower hemoglobin. We may even want to transfuse them below 9. So 7 to 8 is generally the rule of thumb. At that point, we'll transfuse them with packed red blood cells. But definitely feel free to transfuse at a higher level if there's signs of cardiovascular or respiratory compromise, like angina, chest pain, dyspnea, and so forth. Patients should be transfused with platelets if they drop below 10 to 20 microliters, and patients who have M3 AML, the promyelocytic leukemia, they should be transfused at less than, if they go less than 50,000 per microliter, but you definitely want to maintain them at a level greater than 20 microliters. 20,000 per microliters, 20,000 platelets per microliters. And if you have a patient that's got present hemorrhage, so CNS hemorrhage, GI hemorrhage, then you want to maintain them at even higher levels. If the patient presents to you febrile, and this is a common presentation in the ED where you have a patient with leukemia who is running a fever of 103 degrees, parents know to bring their kids right into the ED, or at least they should know, bring their kids right to the ED immediately if they're running a fever. Any kid, or anyone really, kid or adult that has leukemia that also has a fever, they should be admitted immediately. You're going to be getting pan cultures on them, which means sputum culture, most importantly blood culture, urine culture, and so forth. And you're going to administer broad-spectrum IV antibiotics until you get the results of culture, particularly the blood culture. Best antibiotics would be, for broad-spectrum, would be a third-generation cephalosporin, plus or minus vancomycin. Particularly, you're going to want to add the vancomycin if they develop a fever in the hospital, because we're worried about MRSA. So IV Rocephin plus or minus vancomycin for 5 days. That's generally a good broad spectrum coverage for a febrile leukemic patient. Treat them for 5 days. If they don't get any better, then you can add an antifungal. The one I would go to would be amphotericin B intravenously. And you don't really necessarily need to know this for the USMLE, but a lot of oncologists will treat their leukemic patients prophylactically with antibiotics, Bactrim, nystatin, and that's more for the oncologist to do. During the induction phase, all patients should be getting allopurinol, and allopurinol will prevent tumor lysis syndrome, which, remember, what the chemotherapeutics do is they destroy cells. And not only do they destroy cancer cells, but they destroy healthy cells too. And the result of destroying cells is that you're going to get uric acid into the bloodstream. And when you have higher levels of uric acid, you can develop gout and so forth. So allopurinol is useful during the induction phase to prevent tumor lysis syndrome. You should be monitoring the absolute neutrophil count. The absolute neutrophil count will be given to you on the USMLE. It is something that can be calculated, but I do not believe you have to know the formula of how to calculate it, because on most labs that you get in the hospital, the absolute neutrophil count is already calculated for you. So what you should know is that the infection, what the absolute neutrophil count is it's the mature white blood cells. So those are the white blood cells that are actually going to fight infection, unlike the leukemic white blood cells. And what you should remember about the ANC, absolute neutrophil count, is that infection risk is going to increase when the ANC count drops below 500 per milliliter, and it's going to dramatically increase when it drops below 100 per milliliter. All patients who are with acute leukemia getting chemotherapy should be put on a neutropenic diet, and that means no fresh fruits or veggies because they can carry bacteria, mold, fungi, and meat should be cooked thoroughly. And any signs of leukostasis being sludging of the blood due to the leukemic white blood cells getting into the bloodstream, that should be treated with exchange transfusion, in which you're taking the patient's blood out and putting whole blood into the patient's bloodstream. Leukostasis can present as mental clouding, decreased cognition, and so forth. So definitely something to look out for. And that's pretty much it for acute leukemia.